This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. It is my great pleasure this morning to introduce a dear friend and colleague, Chrisandra Shufelt, who is a professor and chair of the Division of General Internal Medicine at Mayo Clinic in Jacksonville, Florida, and associate director of the Women's Health Research Center for the Mayo Clinic Enterprise. Dr. Shufelt is a women's health internist with fellowship training in vascular biology and women's health at Cedars-Sinai. That's where I worked with her very closely for close to 7 years. Chrisandra is one of these unique internists who spent quite a bit of time in the cath lab wearing lead and trying to understand coronary physiology and participating in coronary function testing. She's certified in menopause. She's a certified menopause practitioner and has several national and international leadership roles in the American College of Physicians, the European Menopause and Andropause Society, and the Menopause Society, where she was the past president in 2022 of the society and a past board of trustees member. She's published over 200 publications in the area of women's health and has co-authored several scientific position statements on menopause and hormone therapy. She's served as the lead member of the 2023 non-hormone therapy position statement for the society as well. Um, Her K23 and subsequent R01 have focused on young women with hypothalamic amenorrhea and evaluating the impact of immune and vascular health and really understanding what are the processes that lead to cardiovascular disease in young women. And I'm going to turn it over to Dr. Shufelt this morning to talk to us and update us about what a cardiologist needs to know about menopause hormone therapy.
Good morning, everyone, and I apologize for not being there in person. I did, if you heard it earlier, I got this lovely spring virus, which I'm still recovering from, but I really appreciate the opportunity to talk and really talk about menopause and women's health and what specifically a cardiologist needs to know. Really, this came out of a lifelong passion, having been in the Women's Heart Center at Cedars-Sinai Medical Center, where we actually established a menopause program within that center. And so everyone 20 years ago was scratching their head going, what do we do about hormone therapy? And that really came out of a need and to understand like what is the real intersect between hormones and heart disease. So my hope and aim for this discussion and grand rounds is to leave you with the knowledge that you should know as a cardiologist when you have a female patient in front of you coming in midlife, whether or not she's got risk factors or had an NSTEMI or coronary microvascular disease. So my disclosures are my R01 funding's not related to this. I do advisory board for menopause education. Bayer has a very large campaign right now for menopause education, both by provider as well as a patient. So really, I split this discussion into two halves, and we're going to concentrate. The first half is going to be really on what is the role of age and time since menopause and other cardiovascular risk factors to determine if hormone therapy is appropriate for your cardiovascular patient and concentrate on that high risk patient. And then for women that are very high risk or should have contraindications, what are treatment options? I know that you would not be prescribing hormone therapy or treatment options, but it's important to understand the understanding of the GnRH pathways that have led us to new non-hormonal treatment options, and then really understand the cardiovascular and cardiometabolic risk factors that are more associated with menopause and midlife, as opposed to good old chronological aging. So I always say that menopause is an opportunity for cardiovascular prevention. I think that we can all agree that women develop cardiovascular disease a decade later in men. This was really attributed to the decline in estrogen hypothesis, decline in estrogen, increase in cardiovascular disease events, and therefore replacing hormone therapy would be the right thing to do. And that's really the led to the leads of the Women's Health Initiative, which we'll touch on slightly. But we now know that's not necessarily the case in terms of replacing estrogen, therefore, is the fix. But we do know that there's a notable increase in midlife. And while we look at a woman's life expectancy in both the European and US, It is 81. If we look at the reproductive age of a woman, the average age of menopause is 52 in our country. And so that really looks that it's about half of an adult woman's life will be spent in menopause. So we're trying to sunset the term postmenopause, or that there's a period of time that you won't be in menopause anymore. It's really more about menopause is a reproductive stage. The American Heart Association in 2020, led by Samar El-Kohardi, wrote a position statement on the menopause transition as a period of accelerated risk. And it really got buried because of another little virus that was going around. But the COVID pandemic really didn't give that position statement its due diligence. And so I'd encourage anyone that's interested in women's heart disease to look at that statement, because it really holds true to and summarizes what we know today as the risk in menopause transition. But 6,000 women every day will enter menopause in the US. So that equals 2 million women per year. So this is not a small transition. It's not a small number, and it's important that we use this opportunity for cardiovascular prevention. All right, a little busy slide, but what are we talking about for menopause transition? And I think this is the most important slide when it comes to understanding. This is the SWAN, the stages of reproductive transition. So this is straw plus 10. So this is a staging system for reproductive aging in women. And all I want you to do is concentrate on this big 0 right here. And the 0 really indicates the final menstrual period. Two phases before that is the late and early menopause transition. And this is where we start to see cycles change. Estrogen, I call it the stock market of hormones. It goes up and it can go down. It can swing pretty widely. And so women can become symptomatic during this period, but it's also a period of accelerated cardiovascular risk. So that's what the menopause transition is. Once you hit the final menstrual period, then you are in the postmenopausal stage. But perimenopause, oftentimes you hear that term too, encompasses the first 12 months after the final menstrual period. Now, the menopause transition can be anywhere between 2 and 7 years long, and there's no way to predict a woman's period of time. But we know 75% of women have vasomotor symptoms, but 10% of them are the super soakers. These are the women that come in, they are having drenching night sweats, they're having to change their shirts at night. I have my vision here is to look at these women in a different light, because I think they are vascularly different than the 75% of women that have vasomotor symptoms. But they can occur even before the final menstrual cycle during that menopause transition. And it's not just hot flashes and night sweats. We can also sleep disturbance, mood changes, recall, cognitive function difficulties, even like anxiety and depression. We published last year at Mayo Clinic the quality of life on work productivity, and our publication got a lot of press, which then subsequently called to action a position statement by the Menopause Society, as well as a global position statement on menopause in the workplace. But it's an annual US loss, it's $1.8 billion. And these are women that are in their prime of their career. Usually, these are your women who are in their mid 50s or early 50s who are now leadership roles, in C-suite roles, and oftentimes, quite frankly, I have patients tell me they're leaving their jobs. And we know that menopause hormone therapy has rates are low. We have presented and about to publish a large Optum database that shows that the menopause hormone therapy prescription rates have not changed since 2020, since the results of the Women's Health Initiative. So over the last 2 decades, it's dismally low. It's less than 4%. In fact, our publication is now showing it's 2.7%. So we do need to indicate that these women that are appropriate for hormones should be getting in. But what about hormones and heart disease? So I'm going to walk you through a patient, and she comes worried about her heart health. She's having bothersome vasomotor symptoms, her sleep disturbance, irritability. She's got some mild vaginal dryness. Her internist told her to try other ways to control her hot flashes. Her gynecologist told her it's fine to go on hormone therapy. That's why she's coming into your office, because usually it's the cardiologist that is the deciding factor. At least that's how it was 2 decades ago when we started the women's menopause program in the Women's Heart Center. Her last period was 18 months ago, so she's now in menopause. Her past history, she had an APO, with her second child. She has hypertension now. Her mother had an NSTEMI. Her father had CABG at 70, and she's on very few meds. But she comes in to ask you, I have friends that have heart issues and say hormone therapy will give me a heart attack or a stroke. But my other friend told me I need to take hormones to prevent heart disease. As the cardiologist, what is true? Well, what is missing to help us guide this decision really is her age. So this picture of her on the right is very general. We don't really know her age, but what we do know is age is an important variable in considering the time of initiating hormone therapy. So going back now in history, what we thought we knew, this was really that true hypothesis, which was pretty logical at the time, that menopause was associated with a sudden dramatic drop in estrogen and accelerated cardiovascular disease. Therefore, replacing it would be cardioprotective. And menopause really was thought to be a disease model. So the, there was a disease model of menopause. Menopause was a natural age related condition, but estrogen was needed for long term treatment of chronic prevention. So if menopause was a disease, we would need to treat it. Could you imagine that being said today? And there was a book that came out called The Feminine Forever. And this was Robert Wilson who called this a serious, painful, and often crippling disease. And if you've ever had a chance to read the rest of it, he went on to say that women would be much more pleasurable to live with and said all sorts of incredibly difficult stuff to read if you were to put it in our context today. But he truly believed that menopause was curable. The Women's Health Initiative really led for an effort by Bernadine Healy, who, as we know, is a cardiologist and was the head of the NIH. Interestingly enough, the history behind this was not a line, this was a separate line item by Congress. This was not budgeted in the NIH. So Dr. Healy really wanted to answer the question that was really based on hypothesis variables. Is in a clinical trial design, does hormone therapy prevent heart disease and other chronic disease? So that's what really led to the Women's Health Initiative. So, in order to understand this briefly, it was 26,000 women who were randomized to either estrogen with progestin versus placebo that had a uterus, or estrogen alone versus placebo. And since it was a double blind trial, women could not have symptoms, or they would really know within a week or two if they were randomized to hormone therapy. So, by design, these women were much older than the average age of menopause. And the average age in the clinical trial was 62 years old. And the average age of menopause we know in the US is 52. So that's a true decade that they were studying women who had not been on hormones or had slightly been on some hormones that were now into the randomized trial. So what we now know, outcomes of if you compare the observational studies to the Women's Health Initiative, if you look at everything from coronary heart disease, stroke, pulmonary embolism, and then fracture, breast cancer, and colorectal cancer, the OS are really the cumulative observational studies to date, and the Women's Health Initiative really did align up with almost every single outcome except for coronary heart disease. There was a divergent result that showed the observational study consistently showing a relative risk that was protective, where the Women's Health Initiative in the combined trial showed that there was a higher risk of coronary heart disease. But in the 2013 paper by Joanne Manson, this was an eloquent study from the 50,000-foot level. What I'm going to have you concentrate on is the women that entered the trial. There were about 30% of them between the ages of 50 and 59, and these are the ones that I circled in this image here. And what you can see, the absolute risks by the trial, the upper bars indicate the estrogen with progestin, and the lower bars indicate the estrogen alone. And even if you were to stand back without looking at everything, what you can see is that the placebo is in the light blue and the active treatment is in the dark blue, and really low relative risks if women were between the ages of 50 59. And then as women age and started the hormone trial between 60 and 69, or started it between the ages of 70 and 79, these risks go dramatically much higher. And so that's really come to the understanding of what we call the timing hypothesis. And the timing hypothesis indicates that if there is a woman who's starting hormone therapy at or around the time of menopause and doesn't have significant cardiovascular risks, then presumptively her endothelium and her vascular health is relatively intact. So she has a healthy endothelium, and in a healthy vascular vessel, you can see that there's beneficial effects of hormone therapy because we know there's estrogen receptors within the lining of the endothelium. This they can attach, have an effect of vasodilation, decrease inflammatory activation through increasing nitric oxide and decreasing some of the pro-inflammatory cytokines that you can see there. And then would this potentially prevent lesion progression? That still has not been answered, but we do know in a woman who is healthy at the time of menopause that there is no detrimental effect from a cardiovascular standpoint. We don't know if there's detrimental benefit, but we can say that there's no detrimental um, uh, negative effect. As opposed to the vessel on the right here, we see that there's an established plaque. There's the dysfunctional endothelium. We've got most of the cellular receptors are buried within this necrotic plaque, as well as the proliferative smooth muscle cells. And when you get decreased estrogen expression like this, you cannot get vasodilation, and then that is, we all know, the increased inflammatory activation. And specifically in oral estrogens, this could actually, because of the pathway that they first pass metabolize in the liver, you can actually get plaque instability because one of the byproducts when you metabolize an oral estrogen is MMP9, which can destabilize this fibrous capsule within this atherosclerotic plaque. And that's become to the understanding of what we call the timing hypothesis. So the timing hypothesis really indicates that is there a difference between an established plaque versus an early atherogenesis in women who are healthy at the time of menopause. Now, there's a lot of women walking around with vessels that look like this on the right-hand side at the time of menopause, and so those are the women that you might be seeing in your office that we don't want to be giving hormone therapy to. But what if this woman was 35 years old? She comes in, she's starting to get some hot flashes, and she just had an infertility diagnosis workup. She had no idea why she wasn't having her cycle, and she had an FSH of 93 and an estrogen was really low at 12. She's had no menstrual cycle for 18 months, and she's just having sleep disturbance. Would we want to give hormone therapy in this woman? Well, the answer here is this is a diagnosis of POI or premature ovarian insufficiency, or what in specifically we call premature menopause. But this is a woman that we would want to physiologically replace her with hormone therapy because if you were to put her up against her age matched best friend, that woman would have estrogen endogenously up through the age of natural menopause, which is 52. Now, if she comes in and she's 43, she's had no menstrual cycle for 18 months. She's just having some night sweats now starting and sleep disturbance. So now if she comes in at age 43 as opposed to age 35, would we want to give her hormone therapy? Same workup. FSH is elevated and an estrogen is low. But yes, we would absolutely want to continue without any, she doesn't have any contraindications. We would want to give her hormone therapy because this is a diagnosis of early menopause. Early menopause is menopause before the age of 45, and premature is before the age of 40. So both of these is where we really use the term hormone replacement therapy. If you've heard most of um, my terminology to up to this time, I've been using the term menopause hormone therapy because we are also sunsetting the term replacement if you're using it after 52. But if you have a woman who is in early or premature menopause, this is where we call it PHRT. So it's physiological replacement. So the lack of estrogen really is an endocrine deficient state. And these are women that need to be treated as such. We wouldn't have a woman who is hypothyroid walk around for the next 20 years. It's a little different analogy, but we do need to consider this as an endocrine deficient state. So again, estrogen hormone therapy should be given to women, and it needs to achieve replacement levels that are physiologic. And what is that? That really is a higher dose of estrogen than we do use for natural menopause at the age of natural menopause to treat symptoms. What do I mean by physiological replacement? Well, we would prefer to achieve the replacement levels of an average cycle of that woman, and that's about 100 micrograms. So a zero point 0.1 patch or 2 milligrams of estrogen. The goal is not just symptom management. So if they don't have any symptoms, I'm not treating symptoms. I'm treating them in terms of their replacement. Now she's 52. She's got no menstrual cycle. Her ASCVD risk is 2.2. Well, ASCVD is a challenging calculator at the time of menopause because we all know this is very much age driven. I do ask well beyond ASCVD risk factors. I ask also about APO. I even ask about menstrual cycle histories. Things like PCOS and functional hypothalamic amenorrhea are all really early signals that we can think of for future risk of cardiovascular disease. But in this woman, she's good to go. She's got no risk factors that would indicate that she would need to be on not on hormone therapy. Even if we take it back to that early clinical vignette, that she has hypertension and a family history. Her ASCVD calculator is low, and we would give her the green light to start hormone therapy. Now, what if she's 62? If she hasn't had a menstrual cycle for 10 years, she's never been on hormone therapy, someone drew her hormones, which we know would be undetectable, but I often get women getting hormones checked no matter what age they are. And after a certain age, at the time of menopause, it's not even recommended if a woman's gone 12 months without a menstrual cycle. Her ASCVD risk is over 5, and her main concern is weight gain, hair loss, and fatigue and night sweats. Well, and now with a lot of social media, kinda out there. There's a lot of other concerns that women have around menopause that they think hormone therapy is gonna be the panacea of treatment for. But in this woman, we would really put our hands down and say, "Nope, you're not a candidate." In fact, you'd have an increased risk for cardiovascular disease and events, and often a lot of these other things are not gonna be taken care of by hormone therapy itself. I mentioned the first pass metabolism in the liver, specifically to oral estrogen, but the transdermal therapies, which are the patches or the gels, and there's also a systemic vaginal ring. They do avoid first pass metabolism in the liver. While we don't have large randomized clinical trials to assess their relative safety, we have small trials on intermediate outcomes like the KEEPS and ELITE trial. But really, those studies have helped lead us to understand that there's been less effect on clotting factors, triglycerides, CRP. If you've ever measured a CRP in a woman on a birth control pill, an oral birth control pill, contraceptive, you will see that that could be falsely elevated. It has less impact on blood pressure as well as mammography density. And so, that while this is cardiovascular health we're talking about, it is important to note that 50% of those mammography reports are going to say your breasts are dense, but we do know that the transdermal estrogens have less effect on that. But what about transdermal hormone therapy and safety? Well, really, this is the small clinical trials finding. Well, what about lipids on transdermals? Well, there's been 11 randomized clinical trials, one cohort study, reasonable quality. So we know oral estrogens have greater effect on lowering LDL, but they increase triglycerides. Transdermal have very neutral effect on both HDL and LDL, but they do lower triglycerides. VTE, low quality here because case control studies and three cohort studies, oral systemic increased the risk of VTE, and transdermal had a very neutral effect. So again, going back to the understanding of the first pass metabolism, and then what about MI? Poor study quality to date. No study design has really compared them between systemic and transdermal. So, how do I approach hormone therapy in your cardiac patient? Evaluate number one, time of menopause. And if they're within 10 years of final menstrual cycles and they're having bothersome symptoms, then these women could be evaluated for hormone therapy. Here's your contraindications: coronary heart disease, stroke, TIA, PE, VTE, clotting disorders, active liver disease, but really those are the ones that are specific to the cardiovascular health. What we know is that there are multiple risk factors. I mentioned ASCVD briefly is not a great because of at the time of menopause, a lot of women, I calculate their ASCVD is under 2% because a lot of it's age driven. So I do take into account um, all of these other risk factors. This is a published paper that we published in Circulation Research, along with colleagues from Brigham, that this scheme is actually printed in there. But I look at coronary artery calcification as well, being a moderate risk if it's between 1 and 99. Those women that are at moderate risk fall into that orange yellow category. So you may consider hormone therapy, but that's the transdermal formulation that should be used. If they're women or very low risk, it's their personal preference if they want to use oral or transdermal. What about our cardiovascular risk factors? Well, timing really matters. The risk of heart disease appears to be low in women who start after the time of menopause, and consider transdermal for women who have moderate risk. And we know it's not government approved or FDA approved for primary or secondary prevention. I get this question a lot, that I should be taking hormone therapy to prevent my cardiovascular disease or heart disease risk. So it's really more about the old terminology is out, the lowest effective dose for the shortest duration of time. This was really sunsetted quite a while ago. The 2022 hormone therapy position statement now talks about the appropriate dose, the appropriate duration, and appropriate route of administration. Now, interestingly enough, I asked ChatGPT the other day what was the appropriate duration of time for hormone therapy, and ChatGPT went back to this old statement: lowest dose, shortest duration of time. So I think we need to get this mantra out of people's minds and out of ChatGPT, because some people are going to that and using that for their medical knowledge. So it's more about appropriate symptoms for the appropriate individual. What about GSM, which is the new term for vaginal atrophy, which is a genitourinary syndrome of menopause? It is actually impacting about 50% of menopausal women. They do not, this is a tissue that will not get better on its own, meaning if you do not treat it with topical vaginal estrogen, it will not improve these symptoms. And these symptoms can be chronic and progressive and result in atrophy of both the labia, the vaginal tissue, and the urethra. And that then can result in more infections, dyspareunia, as well as a host of a lot of other concerns. Topical vaginal estrogen is minimally absorbed, so a progestin agent is not needed if it is only topical vaginal estrogen is used. So when hormone therapy is considered solely for GSM, local vaginal estrogen therapy is generally recommended. And even in cardiac patients, if there's a contraindication, if your patient's had CABG, if a patient's had a MI, a PE, we still consider this an appropriate treatment because the systemic levels are minimal, if any, is absorbed systemically. And there are low dose vaginal preparations that are creams, vaginal rings, and tablets. There's also vaginal DHE that will convert into estradiol in the tissue itself, that's available for daily dosing. So this is an estrogen that I oftentimes see my patients who've had cardiac evaluation or had a cardiac event, that they come back in to see me and they've been taken off all of their hormones. And this is not a hormone that we should be stopping and consider, because of considering quality of life. And the vaginal tissue can have a lot of outcomes if we do not treat that tissue as that woman ages. So please, as we walk away from this discussion today, take into consideration that vaginal estrogen is important and it does not need to be held after an event. What about my friend who just had a heart attack? Does she just have to suffer in silence with her hot flashes? Well, there's great non-hormonal options available. When I say great, I mean 75% improvement is what was been seen. But we do have a brand new kit on the block. It just was approved by the FDA, called fezolinetant, and elezonitant is a second one that I'll discuss that's going to be upcoming for review by the FDA, hopefully in the next 6 months. But here are the contraindications, as I mentioned. But here's in alphabetical order, this is what the non-hormonal position statement recommended. Fezolinetant, so this is alphabetical order, is a drug that is a neurokinin agonist. And what it does is it works in the area of the brain that controls the hypothalamic pulsatility, and actually it can, that which is what controls hot flashes. Gabapentin can also be used, and can also be used at low dose at night. Oxybutynin is also one that is used. That's been more recently discovered as we, sorry, my computer is acting up. Oxybutynin is as a newer one. Oxybutynin we know is used for overactive bladder, but we certainly know that oxybutynin in older individuals can come with some cognitive concerns and cognitive decline. So if that's being used, we use it in younger women in low doses for short duration. The SSRI and SNRI are probably the most commonly used in terms of what is known to date about about where the vasomotor symptoms are starting in the hypothalamus and how the role of serotonin actually can help regulate that area. So that's why the SSRIs and SNRIs are used. Paroxetine actually is an on-label indication at 7.5 milligrams for vasomotor symptoms. But the fezolinetant and elezonitant upcoming is really was really discovered out of an understanding of where vasomotor symptom physiology begins. And this starts in the candy neurons, so the kisspeptin, neurokinin, and dynorphin. This is a neuronal plexus that sits above and adjacent to the hypothalamic, the thermoregulatory area in the hypothalamus, and loss of feedback to this pulsatility and release of the GnRH during menopause is really what is thought to be the regulation of the hot flashes itself. So it's triggered by this hyperactivity of these candy neurons and this hypersecretion of the neurokinin B. So fezolinetant is a neurokinin 3 receptor antagonist, and that is why it is used for hot flashes. So elezonitant will be up and coming, and fezolinetant is available now. There was a signal for some liver toxicity in the clinical trial, or liver concerns, I should say, not toxicity. So the FDA requires a baseline liver function test for the first 3 months and every 3 months after that till month 9. So what does the evidence suggest for cardiovascular risk factors? So in the last 5 minutes, I'm going to talk about what are cardiometabolic implications of menopause. I'm gaining weight. I've never had high blood pressure or cholesterol before, and now my numbers are increasing. This is my patients in front of me. They tell me this has to be menopause or this has to be my hormones. Before we go into the cardiometabolic, I just want to touch on the fact that the SWAN study, which is a study of women across the nation, as well as Framingham study from the 1970s, has given us a better understanding of the menopause characteristics related to cardiovascular risk. And even in 1970s, the Framingham study, in this very eloquent matched study of women that were under 40, 40 to 45, 45 to 49, and 50 to 54. If a woman in the blue was a premenopausal age matched to a woman in the red, which is at that age postmenopausal, you can see that this was the first understanding of the relationship of menopause status to incidence of cardiovascular disease. So if a woman enters menopause at an earlier age, there was almost a up to threefold increased incidence of cardiovascular disease. In the 1980s, surgical menopause, which during that time was a lot more common than it is today. So this is just bilateral removal of the ovaries or oophorectomy, as opposed to just what is more commonly done today, which is hysterectomy without removing the ovaries so that there's an intact ovaries. But what you can see here is under the age of 35, the younger the woman that has surgical menopause, the greater the concern for MI and future risk of cardiovascular disease. And while I say that the hysterectomy and uh, partial hysterectomy versus total abdominal hysterectomy numbers have changed, there's a lot of women to consider because they are selectively having their ovaries removed because of genetic mutations. So this is a group of women that we do need to think about in terms of their cardiovascular health as they go forward in the next few decades. What about vasomotor symptoms? I mentioned those 10% that were the super soakers. And this is study from Rebecca Thurston from the SWAN, which is the study of women across the nation. And that study is a longitudinal prospective study of women in the menopause transition. And this is what really we've discovered a lot of the cardiometabolic changes that has come out of our understanding of menopause. But this is actually showing that the worse the vasomotor symptoms or the more vasomotor symptoms, there was an increased cardiovascular disease risk as well as mortality over the 20-year follow-up. So are these women that have very persistent as well as more vasomotor symptoms vascularly different? And that's something that we need to know and we need to answer. But we also need to answer what happens when you give these women back hormone therapy, because that's the other option is we could give them back hormone therapy. They won't have vasomotor symptoms, but are they vascularly different to begin with? So would estrogen even make a difference? Again, here's another study that same study, but showed that the more persistent the vasomotor symptoms, the greater the risk for cardiovascular disease. So if you look at the summary of menopause characteristics, we see that early and natural menopause increases cardiovascular disease risk. Oophorectomy in the premenopausal period increases that risk. Hysterectomy alone, a neutral risk, and then that vasomotor symptoms not only increases the risk of CVD risk factors, but also CVD itself. And finally, let's go through the cardiometabolic changes that we see with ovarian aging, which I noted by the ovaries, versus good old chronological aging, which is our older individual dancing here. So we we know that weight gain is common in midlife, and we know that there's also a shift from lean mass to fat mass. And so when women come in and ask me, "I'm gaining all this weight, I feel it all around my belly, my waist is increasing," we can be, and this is where weight gain assured is more associated with aging as opposed to menopause. But where we lay that weight down is more associated with menopause itself. So ovarian aging, that shift from lean mass to fat mass, you get greater visceral adipose tissue in the abdomen after menopause. So more central weight gain, which we know is the more metabolically active. But what does weight gain changes have to do with actual cardiovascular risk? You can see, well, here's fat mass increases, lean mass decreases, and accelerate adipose tissue increases. That dashed red line indicates 0, which is the final menstrual cycle. So we can see all of these shift and change. But how does this help in relationship to carotid IMT, let's say? You can see that premenopausal years, a very neutral carotid IMT change, as opposed to perimenopause, you get acceleration. When you have accelerated visceral adipose tissue, there's acceleration in the carotid IMT, and postmenopausal years, it does start to level out. So it does play an important role in terms of the risk for cardiometabolic risk in that weight gain. So that's an important knowledge to share with your patients. What about lipid changes? So lipid measurements during the menopause transition, and again, that dashed line indicates the final menstrual period. LDL goes up, ApoB goes up, HDL starts to level off and go down, and ApoA1 goes up. So we do see an elevation after menopause in all of these. And what we also cannot answer is giving women back estrogen. Yes, it might make their LDL look a little bit better, especially if you're on oral estrogen, but that has not equaled preventing cardiovascular events. I know that the EPAT study and a lot of studies by Howard Hodis have shown that changing the LDL pattern is seen with oral estrogens, but we can't equate that yet with actual events. It might make us feel better because the numbers look better, but we can't say that that would assure a woman that they would decrease their cardiovascular events. Increases in LDL-C around the final menstrual period. And so you can see right here, if you have a woman who goes from a lower LDL to a much higher LDL in that menopause transition, that was a predicted probability of carotid plaque. So if you see a woman who really was, I've never had high cholesterol before, and her LDL just sweepingly goes dramatically high, that's a woman who is at higher risk for, and this was actually risk of plaque. What about HDL function? This is a study from the SWAN study. And while cholesterol efflux capacity is really a research tool because you have to use it on samples on not on stored blood, but on active blood, but you can see that the HDL CEC, or cholesterol efflux capacity per particle, as well as the actual function itself, decreases. If you look at within these lines, this is that menopause transition here. So the ability for HDL to clear that first anti-atherogenic step in the pathway diminishes. So having a lot of HDL around during the menopause transition is actually not as valuable as what we had thought it was. You hear women say, "I've got a lot of HDL. I don't need to go on that statin. I don't want to go on my statin because I've been told I have such good HDL." But does HDL actually equate to structural changes? Well, in fact, this was also a study from the SWAN, and and the black bars here indicate the women who had the highest percentile of HDL. If you go back 10 years before their final menstrual cycle, that HDL predicted a lower carotid IMT. but then transition her through the final menstrual period about a half a year before the final menstrual period, and then 4 years after the final menstrual period, those with the highest tertile of HDL had the highest acceleration in carotid IMT. So having a high HDL after menopause was associated with a higher carotid IMT. So that HDL functional change might equate to a structural change as well. So this still needs to be investigated further, but I think is a great start in terms of what we understand for our particle function as well as size. Metabolic syndrome increases over time. If it was just related to time, we would see a nice flat slope. But what we can see with that 0, which is the final menstrual period, it goes up very dramatically. So we know metabolic syndrome can increase at the time of menopause. What about blood pressure and menopause? This is an old debate. This was an eloquent study where they took premenopausal women on the left here and matched them to male controls, so age matched men. And you can see if you have a perimenopausal woman or a postmenopausal woman matched to an aged matched male and followed for 5 years, the blood pressure increased in the perimenopause and postmenopause period. The data is very mixed. Swan has not found an association, but gender differences in blood pressure elevations, as we know, change over the life course. And this was published about 5 years ago through Cedars, showing that it really is a change. This was a large managed based debt system, Medicare based population. And so in this population, you can see that the systolic blood pressure starts to change around 61, 62, and then women supersede men as having higher systolic blood pressure. But we know that menopause starts at 52. So here's my take on this. This is blood pressure may be lower in the younger years, but rises more steeply in the later years. There's probably a small cohort of women that really are impacted by menopause itself in terms of blood pressure. So, in conclusion, what is a practical approach for cardiologists to know about menopause? Well, it's an accelerated period of cardiovascular because of symptoms, hormonal and physiological changes. Hormone therapy is an effective way to reduce vasomotor symptoms, but we don't know if reducing them and those super soakers will help prevent events. When hormone therapy is contraindicated, there are non-hormonal treatments available. And we also know that we don't use it for primary secondary prevention of cardiovascular disease. And those are the risk factors that are associated with ovarian aging. And so playing a role in aggressive preventive strategies are important for women who transition through menopause. I'm going to skip over my question, but end it right here. Thank you so much for having me discuss this important topic, especially in the setting of a cardiology grand rounds. I appreciate it.
Thank you, Chrisandra, so much for a wonderful talk and lots of new information there and terminology, getting us up to speed here. I'll start off with questions, and for those of you who have questions, please either type it in the chat or raise your hand. Hopefully, I'll see you. Chrisandra, so for premature menopause, towards the end, you showed us slides from Framingham that premature menopause increases cardiovascular risk, which is obviously not captured by ASCVD risk score. So then you had that female patient who was 43, who we said it's okay to proceed with hormone therapy if she has had, premature menopause. So I'm just curious as to what you use for your decision making in that, because obviously, our thought was that, okay, if somebody has premature menopause, they're still at increased risk. Um, so what
So,
do you use to kind of determine?
yeah, so my concern is that the Nurses Health Study and the Nurses Health Study 2 have shown also longitudinally that replacing those women decreases the cardiovascular risk. So those are the women that I would want to replace physiologically with the estrogen. Now, it's a really important discussion because what if that woman already has high cardiovascular risk? Is that what you're coming at? If that patient's 40 or 35 or 38 or under the age of 40 and it already has established plaque, already has cardiovascular disease, I would be using a transdermal estrogen. in terms of her overall risk. I guess it would be very situational because contraindications, if she's had an MI or if she's had, those are the women that I do close. They should probably be on a hormone therapy because it's contraindicated. But I take everything into consideration, and there's certain women that I would put on a low dose of an estrogen patch, not probably push it to the high physiological dose because we also need to take into consideration bone health, not just cardiovascular health.
Thank you. And are there any calculators that you use or recommend for cardiologists to kind of, because we are obviously not prescribing the hormones. Usually we're making comments on whether it's okay to proceed or not when we get asked. Is there anything, any of the calculators that kind of help us?
Making a better mousetrap in terms of adding menopausal risk factors into a calculator is needed. So that's something that we're working on and we're working towards. I think as a cardiologist, really coming up with a statement to say, okay, this person's at moderate risk and could be considered for a patch or transdermal estrogen, or if they are at very high risk, so they have had an MI, they are had a cabbage, they've had a PTCA, those are women that you would be, as the cardiologist saying, recommend non-hormonal treatments or tapering off of their estrogen and starting with transitioning them to a patch of estrogen would be the most important way to do it. It's just not, you don't need to rip the Band-Aid off on a lot of these women that come in. You can taper them down slower, and oftentimes if you can do that, their symptoms won't come back in terms of trying to do it over a slower period of time. But I think from my standpoint, what I would want in a cardiology consult is the understanding that these is an absolute contraindication. We should not be putting these women on hormone therapy and we should be taking them off with the caveat of the vaginal estrogen.
Okay, thank you. There's a question from Dr. Maimo. A great presentation. What are some ways we can combat the cardiometabolic effects of menopause?
Well, I think first recognizing it that it is part of menopause transition and owning that to the patient, I think that's important. I have another talk where I go, here's the cardiometabolic changes and here's what to do about it. And I think what to do about it really is starting with what we all do with our lives, this simple 8. It's really concentrating on lifestyle changes, making sure women are doing high intensity interval training, muscle development, because that's really comes down to the weight gain, and then staying on top of their numbers. I use a lot of coronary calcification. I do a lot of CAC. I think I'm unique in that because I'm not a cardiologist. I don't think a lot of internists do enough coronary calcification testing for those moderate risk women, but I do. And so it's really understanding what we can do for that and starting them on appropriately on a statin as well as an antihypertensive. I will say that there's a lot of new research around salt sensitivity in the kidney and the upregulation of the renin-angiotensin system at midlife and in menopause. So what I usually start with are the ACEs and the ARBs in those women.
Hey, any other questions or comments? Now is your chance to ask your hormone therapy questions.
And I put my email up there not only for the point of the talk, but also if there's ever an opportunity that you say, I have a patient, I'm running this by you, because I think there's so many different MIs types now in women, especially from an open artery, from SCAD to Takotsubo, that there's a lot of these cannot maybe not be lumped into one category. And I know we don't have enough data on what hormones are in that setting. We certainly know that estrogen plays a role with SCAD, but what does estrogen play a role with someone that has microvascular disease versus obstructive coronary disease? And I think a lot of the focus to date has been on obstructive disease, and a lot of the guidelines right now have been focused on the obstructive disease patient, but we do need more information on the microvascular women, and that yet has not been done in terms of a clinical trial design. We are hoping to do that soon. So maybe in a few years I can come back and talk about that.
All right, any other questions, anyone?
Can I ask a quick question? This is Peter Block.
Yes.
So you mentioned that you'd like to identify those younger patients who you may or may not treat. How do you identify whether or not they have plaque? You mentioned, well, if they have plaque, I want to be more careful and so forth and so on. But what do? Do you do IMTs? Do you do coronary calcification? Do we have any good ways of figuring out whether there are soft plaques in these women that really signal that they are at higher risk going forward? And if so, how do we identify that?
I think that it's a great question, and I think we all know that coronary calcification and IMTs are not clinically used often now. It's more for a research tool, and coronary calcification would be very unlikely positive in those women. And soft plaque, we're not going to do CT angios oftentimes in these women. I look at it from a risk factor standpoint. And so if these are women that have multiple cardiovascular risk factors. You've got your rheumatoid arthritic or your lupus patients who've been on chronic different treatment options. Oftentimes, I will send them to cardiology first to be evaluated for perhaps for stress testing. That's a leap in a statement. Here's what I do. I really do assume that these women are low risk because they're younger. And they need to be physiologically replaced. I mean, if you have a 43-year-old woman or a 37-year-old woman, that's how I approach it in terms of I gonna match you to your age, match best friend. She's still gonna have estrogen in her body. We wouldn't prematurely remove her ovaries just because she's got risk factors. We would want to continue to carry them forward to the age of natural menopause.
And along the same lines, Chrisandra, are there any updates related to OCPs that we need to know about?
The OCP data really has not changed, even since we wrote a Jack article about 2 decades ago now on oral contraceptive use in cardiovascular disease. It seems to be the main risk is that first year of use, and then a long-term chronic risk in long-term use of OCPs seems to have lower incidence of cardiovascular disease in women. I would equate that to a lot of women that go on OC for a long period of time have underlying physiology. So they've got things like PCOS as well, and it regulates their estrogen, and it regulates a lot of their other risk factors, or they have a hypothalamic amenorrhea. So it's the data really hasn't changed. There's in terms of there are generational differences in the progestins, but we haven't seen an overall change in birth control use and cardiovascular disease. Now, if I have a woman who's 55 and still on a birth control pill, I take them off of it. In general, if I have a woman who uses a low dose birth control pill up through the age, I stop them around 52, and I check their hormones about a month after that, about 3 weeks. But I do not continuously keep them on a combined oral contraceptive to past that age. We know that the risks of clots go increase up to after between that 52 and 55-year age. There's a higher risk of clotting. So I do take women off and I transition them to hormone replacement or hormone therapy at that period. Now, um, and then if there's a concern of pregnancy, I do use a lot of progestin IUDs. But by 55, 95% of women have entered menopause in the US. So there's no need to continue. I know that there's a practice in some areas to keep women on birth control pills to 57. Oh, that should not be. That we should really change that. If you see a woman on a birth control pill, we should selectively recommend them to be transitioned off.
The preceding program is copyrighted by Emory University.